This episode of Healthcare Uncut and Unfiltered is sponsored by Connect DME. Connect DME provides over 4,000 products to patients nationwide for below the Medicare allowable rate, which helps your self-funded plan or TPA control costs for your durable medical equipment spend. Connect DME's products range from walking boots and crutches to CPAP machines and diabetic supplies, all shipped directly to the patient's doorstep. They even provide sleep studies taken right in the patient's home. Visit Connect DME online at connectdme.com to find out how they can help your health plan save on medical equipment. That's Connect DME, ConnectDME.com. Welcome to Season 2 of Healthcare Uncut and Unfiltered.
Season 2.
Let's give it up for the two greatest healthcare podcast hosts to ever exist.
Wow.
It's lofty, but it's true.
I don't believe it, but I'll take it.
You have to take it. Name one more.
Can't do it.
Yep. Number one right here, collectively. Welcome back. It's been a long time. How are you guys?
Phenomenal. I want to know what makes us that great. Brandon, in your eyes.
You really want this?
Yeah, I do. Hit me with it.
You want to know what makes you guys great?
Let's start 2024 off being real with each other.
Oh my God.
Tell us
to share.
Tell us what makes us that way.
Okay, what makes you two great is that you don't have to care about people to do what you do, but you still care about people, and I think that that's really cool. And it's not even healthcare related only. It's just in general. I think you guys are good dudes who have people's best interests at heart. And that's who I want to surround myself with. So
that's awesome.
That's a great answer. That's a whole vibe.
It is.
Oh, we're going vibe again.
Yeah,
we'll take it.
You guys take over.
No, absolutely, dude. I'll tell you what makes us great is we've got a great team. We've got a guy over there that plays the public really well because he is the public and he knows this podcast deal that we're doing so well and you're kind of our rudder. And so thank you very much. And Alex and I we've been everywhere but the electric chair, and we've seen everything but the wind in this healthcare world.
There's a Mark Lockhartism right there.
Yeah. Well, say it one more time.
We've been everywhere but the electric chair, and we've seen everything but the wind in the healthcare world.
And some other places too.
That's true.
Yeah.
Some places we won't want to go back to.
But now it is 2024. We made it around the sun.
Yeah.
One more time.
I prepared a song for us.
Oh, that's awesome.
Just got to find it.
Gonna go a cappella?
Are you? You gonna hit this really?
Yeah, let's do it.
Okay, let's do it.
I cannot wait. Ladies and gentlemen, the great Brandon Lovelace is going to grace us with his musical prowess.
Good enough.
Nope. Okay. Looks like we made it. Look how far we've come, my baby. That's it.
That was awesome.
We made it to 2024. We got a long way to go, though.
Oh yeah, I'm personally pretty excited about this year. It's been, you guys knew. I've told you, it's well documented what I did last year and jumping out of my own and kind of spread my wings and being my own business. But the steps that we went in 2023 and the things that we did and learned podcast wise, vocationally, family, all of that, have me really excited for 2024. I think that there's a lot of good to be done, and some paradigms have shifted. Some things are still the same. But at the end of the day, 2024 is going to be exciting. Ever since COVID hit, I've seen so much negativity about 2020 and 2021, and I came with the 4 stars. 2021's a 1 star. Don't buy again, or 20 whatever. But I had some of my best business accomplishments during those times. I didn't see them as horrible years. I think some horrible things were going on around us, but 2020 and 2021 weren't as negative as a lot of people. You don't have to look very far to hear the comments about how, oh God, this year's been terrible or whatever. But
I think part of what came out of COVID and lockdowns and things in a lot of ways completely changing, you do one of two things. Either you wallow in the misery of it, or that's a great time to reevaluate what you're doing and what.
It's a good time to learn about the blockchain.
Yes. Well, turns out I learned a lot about the blockchain, and then I learned that I trusted it a little too much. But that's a good example of things you get into. You try new things, but overall, you sit back and think, "Is this what I want? Like, is this the career I want? Is this, the direction that I need to be headed in? Is this physically, am I doing the right things to be healthy? And I think a lot of people did that. I think you can look at there's a lot of negative, certainly, out of the time of COVID and even now the after effects of that. But I think a lot of people, whether you talk about a lot of jobs shifted to work at home and people realize, oh, this is amazing. And I'm more productive at home and I'm going to do my own thing now. I'm going to now work, maybe they changed jobs. Maybe they started a new business. Who knows what they did? But I think a lot of people took that time to do something positive for themselves, because it made very clear that you might have been in some rat race and you realize now, oh, what's worth my time? What's worth my energy? And I think a lot of people shifted that.
Sure.
And they've not looked back. And you see that in statistically in a lot of the jobs numbers, and like it was always strange to me, sort of towards the middle of COVID, but tail end of COVID, it's like, we had a really hard time hiring people, and I know like maybe the a conservative narrative or liberal narrative, whatever. There was a lot of extremes about people are just getting paid to stay home. I don't really buy that completely. I know some of that did happen, but I think some people just changed sectors. So like healthcare, what we're talking about, I think a lot of people in healthcare left. Nurses and medical assistants and people that were in the middle of chaos and risking their own health and at points were probably scared for their own life to go to work because that was the message being spread across the airways. They're like, I'm out. And they went into some other industry and they're not coming back, So being in healthcare trying to hire people, it was strange. You're like, where did everybody go? Like, we're not getting any hits on, any kind of job postings. I think there's a lot of people that avoided healthcare jobs because why? Why risk your own
also
safety?
Also a very underappreciated moment in time during all of the changes in the world. It felt like nobody knew what was really going on or how much work they were actually doing in the hospitals and all the, I think it was all the cleanup, right? It was like cleaning every room after somebody would walk through it, like outrageous. But it is right. There's so many people that left their jobs and started new things, which plays right into the fact that most healthcare is offered by your job. So you've got all these people who are just in this free world now with nothing, and there's a lot to learn. And that's kind of the stance I've taken is there's a lot to learn about healthcare, and I've been guided since all that from you guys. But it is fascinating, right? There's a lot of people who quit their jobs and maybe started their own thing, and then they were tasked with, oh crap, I have to figure out healthcare. I have to. You don't have a choice.
Yeah,
you have to.
It's a great observation. You don't have to look far on the internet to find data to support this. And the words that you look up are called the Great Resignation, and that's terminology used openly among. My wife's a recruiter. She does some recruiting in the HR space, and that is what people are calling that time frame, is the Great Resignation. And people left cultures. They didn't leave employers. They didn't leave bosses. They left cultures. And I think the reason that occurred is because they found out quickly that I can be as productive at home as I can in this job, and this job that I'm going to in this workspace that they provide for us is toxic. And that provided them the COVID and the $1,600 a month that the government gave everybody, provided them the platform bandwidth, whatever you want to call it, to seek out the why of what they're doing. Why am I cleaning these hospital rooms? Why am I, showing up at the ER at midnight? Who goes to the ER at midnight? Why am I doing these things, right? And they said to themselves, I've always wanted to be a musician, or I've always wanted to write, or I've always wanted, and it caused a lot of changes. And I don't think it was so much that they didn't love their job. It's that they weren't doing what they were called or were passionate about, called to do or passionate about. And the Great Resignation, there are a lot of documents written about it. And your observation is one that I haven't really considered, and it's benefits. Healthcare benefits keep people at jobs quite often if they're good, if they got quality benefits. People will leave a job with bad benefits in a heartbeat.
Yeah, but they won't. They'll stay at a job with bad benefits just because of the benefits, even though they're bad. It's
right.
The hump to get over to actually quit what you're doing, that's already like secure. You know what you're getting monthly.
It's a guaranteed check.
The hump to get over that to go on your own is outrageous. It is way too high. And anything like, oh yeah, I know they're not the best healthcare benefits, but there's something. And if I got rid of that, I'd be paying.
I'd have nothing.
Yeah, $2,300 a month to get the equivalent of that.
Especially if you have health issues.
Yeah.
If you're currently using the system and relying on those benefits, as bad as they may be or as good as they may be, to the idea of leaving,
yeah, you're stuck.
You have to have that care because you're in some situation, whether it be long-term healthcare issues or even a short-term issue. I think it absolutely has a part of that decision for anybody looking to change careers or jobs or whatever. It has to, which is also why it's, maybe Mark can expand on this, but do you think it's still, it used to be a very it used to be a recruiting tool.
Sure.
I don't know that it is anymore.
I went to a group yesterday. I sat in with the owner of he owns a plumbing company here in this town we're in now. It's actually on the border between Moore and Norman, but sat down and talked to him, and he doesn't have benefits currently, and he's got enough employees that he's tipping up over the number where you have to provide them, and so he's talking about it, and he doesn't want to do it. He doesn't. It's so expensive that he doesn't see a way forward by doing it, which I get it. I understand. But the law is going to tell him when he hires his 50th employee that he's got to do it. And one of the biggest reasons, Alex, to your point, is keeping people employed. There are other plumbing companies out there that they bite the bullet and pay that. Blue Cross and Blue Shield, but they shove them in a high deductible health plan with stupid copays and horrible drug cards and things like that. And there's no benefit in that benefit. He doesn't want to do that. He doesn't, the reticence on his part is not so much, I don't want to provide benefits. It's, he's been conditioned to believe that Blue Cross is it. He's been conditioned to believe that's all I can provide. And he knows the expense of that. He's got buddies that own, HVAC companies, or they own an electrical company, or they own something else, and they're providing benefits. They've got 60 employees, and he's hearing what they're paying. And that's the broken part of it, is that deductibles were invented, were brought in, were created as an effort to squelch the rising cost of healthcare. And the reason a deductible was invented or came to be was so that some of the rising costs of healthcare could be passed on. It's so that the employee would have skin in the game, is what the terminology they want to use. They want them to have skin in the game. And it hasn't stopped at what it was intended for. It's gone up and up and up and up. We're seeing $5,000 and $7,000 deductibles. The average human being doesn't have the disposable income to cover their deductible in America. It doesn't exist. And so that's the broken piece of it. But he does, back to your point, he does view the employee healthcare piece as a recruiting tool, but it's a recruiting tool that's kind of out of his reach because of the cost of it. And I opened his eyes to the idea that there are other options beyond that. There are other things that you can do to help assuage the cost of it. The guys that do what I do, the brokers in the space, just won't tell you. They won't tell you because it doesn't pay them near much money.
Well, that's the perfect client for a broker.
100%.
They're being told they have to buy it now.
Mm-hmm.
They have to provide this for their employees. and then they've never had it before.
Oh, it's a perfect
So what do you
system.
do? You just open the phone book, or you ask your friend, like, who do you use, and they pass you on to their broker, and you call them, and they're like, oh, I can hook you up. Yeah, we're good. Here's the plan. Here's the cost. Good luck.
The funniest part of this story is I met these guys 3 weeks ago. We had lunch. Toby Keith's, my restaurant.
Shout out
I
Toby
love this
Keith.
bar. I love you, Toby. God, it's so sad. Gone too soon. We met at Toby Keith's over there more, and the guy that owns the HVAC company was there with a buddy of mine who was they were broker client relationship, and my buddy left his firm, and he's looking at talking to this plumbing company owner he's now about to have to provide healthcare. And the guy that owns the HVAC company looked at Scotty and he goes, yeah, just set him up with the same stuff I have. They think that's how you do it, but it's not. It's so not. And what I hope to do, and I've talked to my team that I work with, is that this is ministry level stuff, guys. This is the kind of thing that if you go out and you show these people, these employers, that they don't have to do this. You free them. You break some chains for them, really. And at the end of the day, that's kind of the mission that I want. But they do look at it as a recruiting tool, Alex. They do see it as a recruiting tool.
Is it in the sense that they have to have it?
Not-
Or is it my benefits are better than the others? That's what it used to be.
Right.
It used to be the full package was presented like almost right up front.
part of your comp.
You know, it's a way to talk about comp, but now it's like, yeah, we have benefits. You know, as opposed to what are the benefits?
It is, and I think it's industry specific too, to some level. In the more blue collar industries, they're not provided. They don't feel like they've got the profits margins aren't as unbelievably high. Although the cost of everything's going up, the profit margins aren't as robust as they are in, say, the technology industry or the healthcare industry. The profit margins aren't there, so they're not. They're shoppers. They're harder shoppers. If they can realize that they can provide this service to their employees at a much reduced rate and only pay for, here's the kicker, guys. If they could only pay for the health care that they consume, they're all in. They're all in. But in the Blue Cross and Blue Shield world, they set them up with this $5,000 deductible and your premiums for 60 people, $360,000 a year, and you only consume $250,000 worth of health care. You had all the receipts up, and at the end of the year, all your employees really spent on health care is $250,000. There's a $110K delta there, and that $110K goes bye-bye. But if they can see it in the concept of, I'm only going to pay for what I use, which is the level funded spot, which is what I tried to put as many of these groups in that qualify. It's not for everybody. I'm not a self-funding zealot, but it is something that they need to know about and they need to hear about, because in the self-funding realm, you've got 60 employees and your premium still, let's say it's still $360,000 and your receipts add up to $210 or $200,000, you've got $160,000 delta. That stays in your pocket as an employer. It stays in your bank. You get that money back. And to me, that's where the eyes are opening, and that's where they're coming back and saying, no, this can be a real benefit. This can truly be a benefit. And we go a step further. When we do these types of benefits is we try to add cost containment vehicles for the employer that they can pass on the savings to the employee with Tracy Kreger and Omar Arif and the guys that we've had on the show, the Richie Sontags of the world, the guys that do this in this marketplace, they buck the trend of charging exorbitant percentages over Medicare, and they say, let's get back to the real cost of this and let's pass those savings on employees. We're not looking to erect big buildings and statues in honor of our health system that is designed to screw people. We're looking to bring cost containment to a space that so desperately needs it. And back to COVID, that point I want to talk about in COVID was, I remember, and I don't know if you tell me if you remember this, I remember everybody talking about UHC coming out and they're giving away free vaccines. They're giving away, this, and they're giving away that. And that was the narrative coming out of the health systems. Oh my God, we have a pandemic here. We're going to jump to action. not so fast. UHC doesn't give anything away. And I told everybody that would listen to me, and I was called crazy. You'll see this back in your increase in a year. You'll see this back in your premium increase. You know what kind of increases we saw this year? 24% increases. You think they're paying for free COVID treatments?
No, nothing they do is free.
Nothing. Absolutely not. UHC and Vegas are very, very similar. Vegas wasn't built on winners, and UFC doesn't get built on freebies. Ask their shareholders. You know,
they're like Forbes top 3, right?
Yeah, they are. They
top
are
5. I know.
Oh, 100%. And here's what's even crazier. I think. Did you guys see the Johnson & Johnson whole scenario came back that they were charging their employees exponentially more money for the drugs that they had, and God, I can't remember it. I wish I'd have printed this off and brought it to you. But there's a whole lawsuit going on with Johnson & Johnson, and it's about to implode the vertical integration that we've been seeing. These healthcare carriers are going to be on the hook for what's happening with these companies and utilizing the PBM to make all these profits off the backs of their own employees. They were making these profits off the backs of their own employees. If you look it up, thank you for checking that out, Brent. It's just an absolute crazy deal. UHC, because this PBM did this, is going to shed their PBM purchase as fast as they can, in my opinion. It may not happen. I could be wrong. But with what has happened with this and the egregious nature of what they were charging their employees for prescriptions.
I mean, the crazy thing about those things are, like, I think that's factored in with UHC, with Johnson & Johnson, with any big pharma, with any big...
That's
meaning like, just like, using big pharma example, like, you can read about a lawsuit with the biggest settlement in history.
Mm-hmm.
They don't care. Like, I don't remember what the exact numbers are, but like the largest settlement history was like,
is it
$2 billion or something. But you look at the money they made on the drug was like $12 billion. So
you calculate the fines into the marketing.
I think they probably do. I mean, they calculate everything else. Right? They probably wish, I hope nothing happens and this doesn't ever come out, or there's no suit involved.
But if it does, let's keep about $3 million off to the side.
But they've got a budget for legal fees and settlements and all that stuff. So but they know they're gonna, if Johnson & Johnson charged their own, which I hope I'm getting that right, but whoever charged their employees higher than they should have, made money off them, there's going to be a lawsuit. More than likely, it's going to turn out that they made, just for simple numbers, they made $10 million and they're going to owe fines of $1.5 million or what, it's just not going to add up. I think it's sad that they're so good at playing that game, but that's the facts. I mean, and big pharma is the king of it. They do everything possible to push through then you have to be a new drug. It's just a new spin on an old drug, and they do everything to run out competition. They do everything to run out the small guy. They do everything to push it, get government to push it. Government's pushing vaccines. No recourse, can't be sued for side effects, can't be sued for, deaths even. And they love it. I mean, I don't understand. I mean, that stuff gets my blood boiling because, it's just, on every level it's broken, but nobody seems to want to step up and change it, or they can't, I guess. I don't know. I mean, like the fact that all vaccines do not have to go through a double-blind research study.
Well, we had to get them out quick, man.
No, but I'm saying all.
I remember those.
There's law from the 70s.
Yeah, all the vaccines ever, yeah.
Maybe it was more recent than that. 80s, maybe it was Reagan. I don't remember. But they passed a law that basically was like, no. Like, you can't, we don't require you to basically present research
for vaccines.
You don't have to do the study to say they're safe. Like, you can just put them out there. I don't understand laws like that. Mark and I were talking earlier on the phone about legislation and, what does it take for legislation to have actual teeth? And sometimes it's regulation that gives companies free reign to do, like we're talking about now, big pharma, to do whatever they want with really no repercussions. There's other legislation that seems to have, good intentions and a good spirit to it, but it doesn't really have teeth. For example, the ACA, the Obamacare, like that was the first time we saw price transparency language in any kind of healthcare legislation. But it just said publish your charge master, which is not helpful to anyone. I mean but it was a step that had never been taken. You have hospitals, you have to publish your pricing. So what do? They publish their charge master, which is just, it's unrelated to anything. It's just a price. So you can't really shop on it, but it started the ball rolling, right? So what's next? Now there's legislation, there's rules that have come out that aren't laws. They're just interpretations of Obamacare. And I assume like CMS and Health and Human Services, they come up with these rules. I'm not sure how that process works. But now they're saying you have to publish your prices per payer on a machine-readable file on your website.
Which they dictate.
Well, so that means they're supposed to say, if I look up knee replacement, I should be able to look at my Blue Cross Blue Shield plan rate versus a United rate versus a Cigna rate and then go to the hospital next door and do the same thing. I can see like my plan negotiated a rate of $20,000 with this hospital for a knee replacement. And over here, though, my plan negotiated a rate of $16,000 or whatever it may be. I don't think they're there yet. I'm not even sure they're required to do that at this point, but that is a new rule, and I don't know what the time frame is for them to get that done. But, the first legislation didn't have any teeth. It just was publish some pricing, doesn't help anybody, but it was a step. And then we were also talking earlier today about, there's state legislation coming out. So like Texas just passed a bill, House Bill 2002, that essentially says if you go to a cash payer provider and you pay less than the contracted rate, then you will be, I think it says you'll be reimbursed for that and you'll get credit towards your deductible, your coinsurance, all that. I tried today to find like a review, an interpretation of some sort of like more a legal explanation of what that means. Because again, speaking of no teeth, like if I say I'm going to go get a cash pay MRI, which is what my company does, I can tell them the price, but how do they know if it's less than the contracted rate? Where does that live? Who's publishing that? Who's required to know that? I'm a facility that I don't have any contracted rates.
Healthcare Blue Book.
So I can't tell them what the contracted rate is. And each contracted rate is different per facility. Mm-hmm. So like the hospital's contracted rate for an MRI is different than the independent imaging center's rate with Blue Cross for that same service, then the next independent facility, then the next hospital, then the next, like they're all negotiated individually. So all the rates could be different. But how do you find those out? As someone who's run, multi-specialty clinics, I can tell you even from the clinic side, you really don't necessarily know what your rate is. On some of them you do. If it's a blanket contract you sign that was 140% of Medicare, but it'd take you a minute to figure that out because like some contracts are 140% of 2019 Medicare. Some contracts are 140% of 2021 Medicare. Some
and they change.
So to keep track of all that as the provider, I think it should be on the burden of that health plan, the payer. If I have insurance through a Blue Cross Blue Shield, and I'm going to shop my healthcare, which is what the intention of that bill is to let consumers shop their healthcare. If I'm going to do that, I should be able to call my payer, my insurance company, and say, my doctor ordered an MRI of my knee. What's your contracted rate in my area? They should be able to say, oh, it's $932. Okay, so if I find cheaper than that, then I get credit, and I don't know if you get the difference or
It goes towards your deductible.
I don't really know, but it's again a law that's written, but where's the teeth to it to say, oh, and by the way, now that we've implemented this, payers in the state of Texas, you have to post all of your contracted rates, and then anyone can go search them. And then there's independent companies that compile all that data, because one other issue with the hospital data is there's no uniformity requirements. It just says machine readable. What does that mean? Well, it could mean someone posts like an Excel spreadsheet, but a lot of times it means they post some file that, unless you have a specific software reader, you're not going to be able to read it at all.
Well, it means
but
the government,
it's machine readable, but it's
the government made a deal.
Yeah,
the government made a deal with some software company to funnel everybody through them.
Well, but the good news is there are third party.
It's called Sapphire.
Companies that will go out and aggregate that data.
Right.
So
Healthcare Blue Book,
Turquoise Health. There's I'm not sure if MD Save does that. They have their own. They do have averages though, so they probably pull some of that data. But there's people that are doing that, and you can use them. I think for the most part for free. You put in your zip code, you put in the procedure either by name or by code, and it'll spit out different facilities by price, or an average in your area, or an average nationally.
But does the insurance company accept that as
to
comply with that house bill?
I don't know.
I remember the Healthcare Blue Book, Alex, having red, yellow, and green dots on it. I don't know if it's still the same. I haven't been on Healthcare Blue Book in a while, but I remember going on and testing it out. I met with the guy at MD Save, and they were on an average. The beauty of MD Save, I thought, was at the time, they were trying to push everybody to the hospital MRI with their costs built into the hospital MRI, which tells me the hospital can take that. Mm-hmm. The hospital were losing money outside to people going to cash pay, so they partnered with MD Save, I believe, to direct some more of that cash pay traffic back to them. And so I remember that the Healthcare Blue Book had the red, yellow, green, high, don't go here, maybe go here if you can get in, and if you can get in here, go here. Which there's a lot of validity to that service. There's an amazing amount of validity to service and a lot of procedures and a lot of things, and I'm sure it's grown since we looked at it. We couldn't get in Healthcare Blue Book. For some reason, they wouldn't look at us because we weren't a Medicare facility or something.
I don't remember that.
I can't remember, but we couldn't. They would never list us in Healthcare Blue Book. But to me, they have enough clout to be able to reference against what to me.
Well, and they're all pulling from both national data with Medicare, and then they're pulling local data that the hospitals are required to publish, and they're probably own the software that can read all that stuff. I know Turquoise Health does. Like they pull the hospital's information, and I'm sure they compare it to Medicare or whatever they do. But, we are on Turquoise Health's website too. So, and all that's fine and good. But, like you said, like you asked, who's determining, and at what point is it determined that you did pay less than the contracted rate? Like you would have I don't know how you'd know that up front. You just have to go ask for a cash price, assume it's lower, pay it. But maybe it doesn't matter. Maybe it's like, if the contracted rate is $900 and you paid $950, they're going to reimburse you $900. You're just out $50, fine. Or if it's $850, then they credit your deductible, they reimburse you, and the plan save money. Great. That's all fine and good. I just don't know. The law doesn't, that I read anyway. It's it's very simple, like 1 or 2 paragraph law that they wrote, and again, I think it has great intentions. I just think there's going to have to be more
teeth
attached to it.
More
like
teeth.
The Obamacare example. Like, okay, this is a great start, but what's the end goal? The end goal is that people are paying less per service for their health care. and they're able to
afford it.
the places that are the least expensive and high quality and all that good stuff too.
Well, and quite honestly, I hear where you're at on this legislation. There was some passed not long ago here in Oklahoma in the PBM space, in the pharmacy benefit manager space, and the legislation read that pharmacy benefit managers cannot write in their contracts that plan members are required to source their specialty meds through the specialty pharmacy owned by the PBM. They should be able to source their specialty meds where we are. What is the highest cost medicine out there? Specialty medicines. What was happening? Optum, and I read this in their contract, and we did an RFP on their contract, and this was a deal breaker for an organization. But I want to get to what you're saying. Optum sets up a specialty pharmacy, and whenever a plan member gets prescribed Humira, they require them to source that from their specialty pharmacy. Now, the reason they do that is because they keep them in a profit corridor. They make the rebate. They get all of that. They control more of the money, of the revenue. They allow the legislation came out and said you're not able to keep that person.
What's that called? A profit what?
Corridor.
Profit corridor.
The profit corridor is this. You experience
Makes
it.
sense. I've never heard the term.
And Tracy Krieger posted a deal on LinkedIn that says don't go through the other door. Don't go outside the facility. You did the same thing. If you're at, I'm going to say the name, if you're at OU Med and you're seeing a doctor and they need to give you an x-ray and they send you down the hall through a set of double doors into the other room to get the x-ray, you just got yourself a facility charge because you walked through the double doors. And then that's what happens in profit corridors. The doctor owns a percentage of an MRI. And he says, I want all my clients to go to this MRI. Why? Because it's not a better MRI. It's the one he owns a piece of, and he gets a piece of the action. That's the vertical integration and the profit corridors that they try to build to keep you in their profit. If you get outside of that corridor, they cease to make money. So they want to keep you in a profit corridor. Anyway, they were sending these. We'll get back to that if we want to touch on that, Brandon. Feel free to bring that back
I've
up.
never heard the term.
The specialty medicine pharmacies, they were keeping these employees in the pharmacy space in their own deal. The people should be able to source their specialty meds. Otherwise, there are so many places to get specialty medicines. Their specialty medicine pharmacy wouldn't try to enroll that employee into the manufacturer copay assistance program. They would just charge them for it. Whenever the manufacturer copay assistance program will pay for that drug for 9 months. And the plan saves money. So they wrote legislation. My point in this is coming up, I promise. They wrote legislation to say pharmacy benefit managers can't do this anymore. They can't require you in contract to have to go to the specialty medicine pharmacy that they own. So with this new legislation, do you know what Optum did? They kept sending everybody to their specialty medicine pharmacy and said, punish us. Slap our hands. We don't care. We're Optum.
And that's
it's that
part
point.
of using big gorillas.
Well, and at the end of the day, this legislation you're talking about in Texas, you said teeth to it. I don't want to get political, but I was listening to the news this morning, and they were talking about House bills in our state capitol up here. And this guy, last name's West, I think is his last name, and he's writing legislation to where state facilities can't fly a pride flag and they can't be involved in any LGBTQ, blah, blah, blah. And he said it's a divisive mentality. But the problem with that House bill, I don't want to dive into it. The problem with the House bill is there's no teeth to it. There's not a stiff enough penalty that people won't do it. The problem with the specialty medicine deals, there's not a stiff enough penalty that it's going to make Optum hurt. The problem with the legislation in Texas is that it, to me, and 50 cents in my opinion will get you a really bad cup of coffee. The problem with it is there's nobody's going to, I haven't seen anybody go to jail in handcuffs because of some HIPAA law or some, there's not stiff enough penalty. There's no meat. There's no punitive action on any of it.
And I brought that bill up, and I apologize because I don't know if I read the full extent. Again, I searched.
We're riffing on it.
I clicked on the state legislature website, and it literally was one page that supposedly was the entirety of the.
Was it the White House website that you?
No, it was
but it goes back to
.gov, whatever. But it was. It looked simple and it was clear and it was it was written and then precisely. But yes, like if you don't do that, then what? I don't. There has to be that on the back end. I mean, you can write laws all day that say you can't murder someone, but if there's no consequence, then it doesn't.
Is it a
matter,
law?
It doesn't matter. So maybe there's more to it, and I just don't know. And I'm gonna,
it brings us back to it. Interestingly enough, though, the Johnson & Johnson thing. I sent you guys a text. The headline is J&J allegedly paid its PBM more than $10,000 for a single 90-day prescription of a generic medicine for multiple sclerosis.
Generic medicine.
When the same 90-day prescription could be purchased for as little as $30 elsewhere without insurance, according to a lawsuit. And somebody's comment says, it feels like an appropriate irony that a J&J employee is suing J&J for messing up fiduciary interest for using a PBM that charges a ton more for a generic MS drug.
It's a bad day to be a Johnson.
There's a lot of them. Yeah. It's common.
No, it's crazy. Craziness.
Again, think about how many times did that happen within their own organization. If it's 100 times 10,000, whatever, they got to pay that back.
Yeah.
Who cares? They've made so much money on COVID vaccines. Although theirs was the one that got pulled really quick, wasn't it? Wasn't Johnson & Johnson?
No, Moderna was the one that got pulled quickly, I think.
I think Johnson.
No, it was Johnson & Johnson.
Yeah,
I think it was.
Yeah. So, but they're rolling in it. They don't care. I mean, it's horrible to think that, but it's the truth. I don't know how to change all that. I mean, that is legislation. That is reform. That is.
We need to get Mark Cuban on here to help us figure out how to change that.
I'll give him a shout.
Hello, Mark Cuban. Could you come on and talk cost plus meds for us, please?
It's Mr. Cuban.
Mr. Cuban?
He is doing good work in that space for sure. I mean, it's a pretty simple model, but again, it's limited to generics. I mean, you can't. It's the problem is like. I can't think of a drug right now. Maybe you know one, but they exist today. There's many of them that it's like we are paying X in the U.S. and the same exact specialty drug or non-generic, even if it's not specialty, is X less in Canada, X less in Europe, X less in Asia. Like everywhere else in the world, they don't charge that much. And that's just proof that it's the way our healthcare system works that allows them to make that much money. It's not because the drug's that much better. It's not because it's worth more. And that's the other thing I've been thinking this whole time as we talk through, costs and transparency and, it's like we're talking about little solutions to problems in the healthcare system. When it comes to price, we're not addressing the sickness. And that comes back to essentially what our podcast is about, which is free market medicine. In a free market, price is determined, yes, by the market, by supply and demand, but also it's determined by the cost of goods sold. Like none of the pricing in healthcare,
simple economics,
is based on any kind of actual the cost to deliver. It is literally based on what can we get paid for it. It doesn't have anything to do with.
This is a really bad illness. We can charge more.
Well, there's that. There's the exceptions I'll give people are in. I don't forgive pharmaceutical companies, but if you've created something new and you've patented it and it's only yours. Yes, like you have to make money off of it for a certain time because then it goes generic after 17 years or whatever. I get that. Now you could go the way of polio and penicillin and just give it away because it's better for mankind. But that aside, there are exceptions to but even that within free market, like when people patent any kind of product, they still have to sell it at a price that the consumer will pay. and that price is generally based on what did it cost me to research and develop this thing? What did it cost me to manufacture it? What does it cost me to get it to market? What does it cost me to fulfill it? What does it cost me to warehouse it? All those things go into factor and say, okay, I have, like, watch Shark Tank, speaking of Mark Cuban. They ask every time, like, what's your cost in this product? It's $5. What are you selling it for? You know, if they say 10, they're probably going to be like, not real instant. If they say 20, that's pretty good. If they say 30, oh, I love it. The margins are incredible on this. Like, but they want to know, what cost do you have in it? Imagine asking a hospital that. Like, no. You don't get to just say, this is our price for this. Show me what cost you have. Like, why aren't hospitals like the Walmarts of healthcare?
Of course.
They're the biggest, with the most resources, with the most access to contract negotiation, yet the opposite's happening. They're the most expensive. Why is that? Now, they're going to say it's because they have ERs and they welcome all the craziness, which is kind of true and kind of not true. It depends on what level of trauma center you are. Level 1, yes, you get everything, and it's wild, but even then, at the end of the day, you should be able to cost out, what does this ER bed cost? What does this OR cost? What does this medicine cost? What does this doctor cost to be here? And what does this doctor cost to be on call? And what they could cost out everything if they
still make money
to. Well, yeah, they'd still make money. They make tons of money.
And what you're saying, Alex, is I don't care if they make money. We don't care if you make money on your medicine.
This is fascinating. I've got a computer. I was looking at. It's fun. I'm looking at headlines of healthcare stuff, but on this idea, Martin, what was his name? Scarelli. You guys familiar with Martin Scarelli? Okay, the drug Daraprim. Familiar with the drug Daraprim? It's for people with HIV. It's a drug that kills parasites, and it used to be $13.50 a pill. And then Scarelli is a businessman that bought the company and started selling them for $750 a pill in 2015. You guys remember this at all?
You go to jail?
Went to jail.
Yep.
Went to jail. But here's what's fascinating. He's out of jail. He doesn't work for them anymore. In fact, I can tell you, he now makes $7,000 a month. He has to do community service 20 hours a month. This is his rest of his life. And do you know what the price of Daraprim is today per pill?
13 cents.
Still $750.
Oh, come on. I thought it was going to have a good ending.
The same price from what he got in trouble for is what the pill costs, according to my Googler.
Brandon, how did he get in trouble for? How conceivably, and let's answer that question too, how conceivably does that guy go to jail? And he owned it, right?
That's the way I understood it.
He bought the rights to it, so I would consider him an owner. He buys the rights to it, gets sued, goes to jail. They find criminal intent, and he goes to jail. And he's sentenced to these egregious life, community service, all that. How do new owners leave it at the same price and face nothing?
Well, that's what I say. Like, what did he actually get charged?
Right,
with?
that's
because if it's, I mean, I don't know,
price fixing, wasn't it?
Price gouging. I don't,
I'm trying to find that too.
Because it may be unrelated. Sounds like it is. Otherwise, the price would have dropped.
I know, right? That was the story in the news that was all about that.
Well, it just goes to the sickness in the healthcare world. It's incredibly, incredibly sick, and it's designed that way. And there's a guy that I want to get on our podcast, and he agreed to do it. And I don't know if he will. And his name's Josh Mancuso. And Josh Mancuso is the guy that he does 3 different characters in the room, and he says, "All right, we're the Mississippi State football team. We need to come up with a mascot." And it has the conversation. Yeah, it's his. Yeah. He does one on healthcare, and it's incredible. And whenever I saw him at a bourbon deal with Jonathan Hart. It's a bourbon deal where they raise money for veterans. And they had Josh come up, and I got to sit and visit with him for a minute. And I go, "I really want you on our podcast." He goes, "Yeah, anytime. Let me know. We'll go on there." Because they did this healthcare one. I go, "Why'd you do that?" And he goes, "Because we hate healthcare." And I'm like, at the end of the deal that he's doing, talking to himself, it's like, "Yeah, well, these yachts won't float themselves." I mean, it's incredible, and that's the problem.
It is. There's a gross element of, pharmaceutical companies.
It's one of the seven deadly
big
sins,
players,
Alex. It's greed.
It's really gross. And it's sad that they could still have a yacht and do things the right way. Like you said earlier, it's not that we're against profit. We're like literally free market medicine, like capitalism, like make your money. But you have to have checks and balances in the way that we're not in a free market system within healthcare. And so therefore it cannot work that way. Like it won't check itself. It will be constant greed with the help now of governments and lobbyists. And it's so far outside the realm of a free market system.
Oh yeah.
That what we're doing it's why it's so fun, and it's why it's working too, is because we've just removed ourselves from the system. Mm-hmm. If you remove yourself from the system and you do things the right way, then you will find success.
Sure.
Now, are we going to be UMR in a year? No.
I don't need those problems.
Well, right.
That's a different set of problems.
But at the end of the day, like there are spaces to work in, and every day someone joins this space. A new doc says, "I'm fed up. I'm moving to this model."
True.
A new provider of some healthcare services, you know what? I'm gonna give this a shot. I'm gonna put out some cash pricing. I'm gonna be transparent, and hopefully they run all the way to the end where now all they're doing is cash pay, transparent pricing, and they get rid of all the headache of contracted payers. But every day it grows a little, and we're making a difference. And then these laws come out. Like Texas, there's a similar one in Tennessee. I really couldn't find that one as easily as the Texas one. It may have been from a couple years ago, but lawmakers, legislators, governments are starting to see, we need to push these costs down. They're hurting people. The good guys in whoever they are in state legislature, even at the federal level, if they're really going to do what's best for their constituents, then they are looking at this stuff. What's done about it is yet to be seen.
Yep.
But it's a big issue for employers of all size. And I think part of the reason it's growing traction and growing even more is because now, like we mentioned at the beginning of the podcast, the deductible went from a skin in the game thing to now
unattainable.
It's just a way to get more money out of people.
Mm-hmm.
Like it doesn't reduce the company's cost to give part of the cost to the employee. That's what it, I think, originally was intended for. The total cost was the same, but come on, employee, you're gonna help us save a little money here, right? Now it's employers' costs are way up and employees' costs are way up. Like the whole thing's up. So it's hurting like literally, the month-to-month livability of everyday Americans. And I think if legislators are going to pay attention to that, then they're going to have to look at healthcare.
One of the big things that we saw, one of the big stories whenever I started working with Health Check that we were talking about, and at that time it was Kempton Group, and they had worked with Bank First. And we were talking to Mike Rogers and some of the guys about bringing the Kempton Group into that organization, which in and of itself, Jay Kempton should have been on the list for the state Nobel Peace Prize for what happened there. And here's why. And I'm not trying to blow Jay Kempton up like he needs it, and I'd say that to his face. But what happened there was the board of directors at Bank First had someone on it by the last name of Rainbolt. The Rainbolts are on the board at Blue Cross and Blue Shield. And for Kempton to come in and provide value to Bank First while the Rainbolts stood there and watched was crazy. Oh my gosh, that is that flies in the face of the Blue Cross and Blue Shield system. But here's the part of it. I want to go on record. $1 billion idea right now. $1 billion idea. Okay? And it goes along with what we're saying.
We need a sound effect of some sort.
$1 billion idea.
Okay.
I love it.
Yeah.
That's perfect, dude. That's why I love you. The $1 billion idea is this, and that's a small case sample. But when they went to Bank First, they opened up zero copay services to their employees. They recognized a spike in healthcare, a spike in expense because people were not going to get the healthcare they needed because they couldn't afford it. So my question to you, how do we get an economist to sit down with us and we say, hey, look, what's the dollar value on the pent-up need that's there that people aren't getting their health care, and let's get those people at a much, much reduced rate, at a fair rate. Let's go out and let's provide health care to those that can't afford it. Maybe they all have insurance, but let's figure out a way to provide them some access to health care and put it in, make it available at an inexplicably reduced rate. And I promise you, in America, there's so much pent-up need right now that people aren't going to get care that have insurance because they can't afford to access their care. Let's make care accessible to them. And I'm telling you, you made me think of this by saying they could still have their yachts if they would just do it this way. Well, let's do it that way and get our yachts.
Yeah, the problem is,
Time up? No, not $1 billion idea. Or
the
that's our
last
yacht.
second shot
It's a
go
good
in,
one.
or did it?
Air
yeah,
horn.
yeah.
It went in.
Yeah.
It was a like.
Yacht.
Sorry,
yachts have air
there we go. Two would have.
Yeah. Well,
It's a good idea.
I just lost my train of thought.
Scared me to death. I may have to go to the bathroom.
Man. Yeah, that was.
But I just feel like that we're so focused on what they're doing wrong, what healthcare, what's wrong with healthcare. Screw that. Let's go do what's right with healthcare, and let's figure out how we can access those people who can't afford their deductible and say care's available here.
Well, that is what we're doing. I mean, that's the point of free market medicine, is to say, you can afford. Again, I'll use myself as an example. Like, you can afford an MRI.
Yeah.
When you go to the hospital and you ask them what's it's going to be, like, well, it's going to be over your deductible of $3,000. So which means they're going to owe $3,000. Mm-hmm. But they can go shop and get an MRI for $500 and save that money. Now, and again, I think the intent of this Texas legislation is to give them credit for that $500. Like, they did their plan a favor. Maybe it was motivated because they couldn't afford $3,000, but they went and found it for $500. You're going to give them credit for that. And again, I think the spirit of that's amazing. It's just, let's figure out how they're going to actually implement
Yeah, right. How do we?
But you're right. Like, if they can't afford, if they think they can't afford that health care, then yeah, they're not going to do it because they literally can't. But I don't know. The $1 billion idea there would be somebody would go lobby, and because the only one with the money to do that is the government.
Yeah.
To say we're going to subsidize all co-pays and co-insurance and deductibles for a year, and everybody go get their health care they need.
We need to talk to
we have
Elon.
no
Elon's got the
out-of-pocket,
money.
I'll invite
I don't
him.
know.
I mean, I'll see if he can be on here.
I think Elon needs to come on and we could share this
We
with
could
him.
start a X Spaces and just see if he logs in.
Yeah.
And be like, hey, we're talking about you, Elon. You want to be in on this? I don't think he will.
I think that's exactly who he is. I think that's the kind of dude he is. He's protecting free speech. Why wouldn't he protect these people who can't afford their
Speaking of,
health care?
I think he's been fine with Mark Cuban on X, so that's been fun to watch.
It's been very entertaining. Very entertaining. I think I would love if we could figure out how to get Cuban on here and talk pills, talk drugs. Because I'm telling you right now,
That would be
it's
amazing.
such a big pharma, such a scam. And you can say it online all you want, but they don't care. I want to do something so effective to disrupt big pharma that I got to hire someone to start my car. I really do. I want to make that kind of an impact on them because it's unbelievably disappointing. It's 60 some 7 or 2 or 5% of all bankruptcies in America contain medical debt.
Yeah.
They contain medical debt, bankruptcy, medical debt. I can't pay my bills. I need to file with the courts to tell you I can't pay. And it's medical debt.
Yep.
It's medical debt. They can't afford a $5,000, $7,000 deductible, and that's where we're at. I don't know. It
Wow.
breaks my heart. Breaks my heart. We could riff on this all day long. Do we want to pop into this Old Forester 1924?
I do.
Says something about good spirits earlier. I thought that's what you were talking about.
Well, this is uncut and unfiltered. I mean, at some point we have to stop looking at this. My palms are sweaty. I just stopped.
How about
drinking
you
for-
start pouring it?
Yeah.
And while you do, I'll just read you guys some healthcare headlines from the last couple days. I know that that's not what this is about,
Deep
but
Thoughts
exactly.
by Beloved Handy.
Can I have that as a sound effect?
Yeah, I'll actually put that on the board. Here's the first one for today. Viagra Cialis may help reduce Alzheimer's.
Oh, great.
Just want you to know that that's the number one headline right now.
Reduce old timers or Alzheimer's?
Yeah, no, I said it wrong. Alzheimer's?
Alzheimer's. That is just a ploy to give people an excuse to take it and not be embarrassed.
I mean, somebody paid for that headline, but it's on usnews.com. That's got to be reliable.
Sounds official.
Adding blood thinners to clot-busting meds won't improve stroke outcomes, study says. Scientists have gained new insights into how small intestines work. Thank God.
My IBS is
I've
going
always
nuts.
wondered how that duodenum works.
Yeah, these are all...
Polyp on the duodenum. I met that guy a long time ago.
all right, I got two more. It looks like dogs with larger noses live longer. And
That's an interesting one.
and they've just started legislation for Medicare prescription prices. They're trying to make them go down. So there you go. There's your pour over
I like that.
Medicare.
I think that's a
Can
new
we add that
That's a
segment
new
to all the
segment.
yeah,
News.
let's add that segment to the next all the episodes of our podcast.
Okay, I'll try to remember that.
Yeah.
But
But
also
I'm going to need you to
syphilis
read
is
it
soaring
in a.
in the U.S.
I did see an article about that the other day. Headline.
looking
I
at
didn't
it.
read it. Didn't read it. I
80%
should've.
up.
But you have to practice on reading it in an old timey news voice. And now the news today.
Dan
The first
Rather.
bird flu deaths reported in Antarctic.
There you go.
Teen drug and alcohol use linked to mental health distress.
Yep.
Yeah. Okay.
Yeah,
All right, I'll work
I like
on it.
it, yeah.
I'll be back and I'll be stronger than ever. Gonna find a new level here.
Brandon, address a little bit for our listeners. Why no video today? Help us out.
We are recording a video, but we're going to focus on getting audio out. And I guess if you're really interested in it, the reason is we have 10 other videos that we need to focus on clipping out some cool stuff because the content has been there. So we're going to do a little bit better marketing.
And we did learn a lot last year about producing and putting out podcasts, which I learned that they're a lot of work, especially with video. You know, and we've asked Brandon to do all this stuff, and he does it out of the goodness of his lovely little heart. But it's a lot of work for the amount of revenue that we bring in.
so
I'll let y'all think about that statement for a
So,
second.
so I've not been wanting. I watch podcasts. I hear podcasts. Ted Cruz unapologetically asked for subscribers, listeners, blah, 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 and I just never have been the guy that says that. 2024, my New Year's resolution is to get more subscribers, listeners, and things like that. So we will bring video back, but we're going to be sharing with you a lot of the video in 10, 15, 20-second increments over the next few months, and video will be coming back. Brandon's got some great things working on his end from a podcast deliverable, and I think you'll just see some improvements and some better things. And as we bring, I've got a great couple of guests that I want to bring on. There's a doctor out of Enid named Jonathan Bushman. I texted him yesterday. He has a great story about being in a room with guys that are determining price of care in an area. And I'm going to butcher the story, but I want him to come on and tell it. Dr. Bushman's a direct primary care doctor out of Enid, and he's just a sensational one. And I hope he hops on and hears this because I'm so excited to get him on because he's just a fun dude to talk to. And I think he'll be able to shed a lot of light on the DPC space. He's that doctor that got tired of the health system. and went out and said, I'm going to do this. And his story on how he left is magical. I love it. It's amazing. Other guests, I'm going to reach out to Josh Mankiw. So I want to get him on. I want to play his video at our next video podcast, and I want Josh to talk about it. And he's just absolutely a great dude to talk to, and he's incredibly funny. But he's real. He's an absolute real dude. It was fun to get to know him and visit with him.
I love it.
And so I see some good direction coming. I'm not less excited than I've ever been about this podcast. I think it's going to be fun. I'm excited about where we're headed and what we're doing. What do you guys think of this? 24.
Yeah, tell me about this. This is spicy.
This is an Old Forester product. They're right downtown Louisville. This 1924 is a 10-year-old bourbon that came about kind of to fill a hole between their high-end single barrels and birthday bourbon. It's just kind of that gap. It's about $120 a bottle MSRP. The reason I snagged it is because they only released, I think, 220 bottles in Oklahoma. And so I said, I'm going to get my hands on that. I want to try it. It has some properties. There's a bunch of different barrels mixed into this bottle, and it's kind of a master distiller's private kind of concoction of what he felt like a niche needed. And so this 1924, they don't know exactly. I haven't heard exactly what they're going to be doing with it. It's a 1924 Owensly Brown took barrels of whiskey with different mash bills to a warehouse on Harvard Street in Louisville, Kentucky, and bottled them as Old Forester. This 10-year-old expression honors the 100th anniversary of this occasion. And so I wanted to share it with you guys because when I grabbed it, it was amazing. I thought it was pretty cool. But it's a pretty unique bottle that you can't get just anywhere. It's like that King Ranch bottle, but I think it's got a little more.
Way harder getting that.
Yeah.
Ranch is limited to Texas, which made it hard for us. But
Yeah.
You want to hear? You want to hear something crazy?
We love crazy stuff.
This is a good way to end it.
Okay.
Before founding Old Forester, George Garvin Brown, who also owns many other spirit brands, including Jack Daniels and Woodford Reserve, right?
Mm-hmm.
He was a pharmaceutical salesman.
oh my
In line with
goodness.
his medical background, Brown named the brand after a Civil War surgeon, Dr. William Forrester, and initially sold the whiskey as a medicinal product.
Yeah,
You
he did.
are living in the wrong time period, Mark Lockhart.
That's a prohibition thing, right?
Yeah.
They marketed it as medicine, so they keep making it.
Yep. Well, they didn't want people getting drunk and drinking whiskey. That was what prohibition was about. They thought it was immoral.
Yeah.
Whiskey was immoral, and so they outlawed. They prohibited it from being sold to the public. If you got a prescription from your doctor to help manage your colic for your kid or whatever you needed your whiskey for, you could get a prescription for it and go get it. So there are a lot of distillers out there making. I talked about Green River when we had Green River. It had one of the older distillery numbers on it. I don't know if they put the distillery number on this deal. Some of them do, some of them don't. But it was distillery number 10, and it got put away because they couldn't sell medicine as a prescription. Well, some of those guys sold. There's a whiskey out there called Orphan Barrel. Have you heard of that?
Mm-hmm.
It's the Fable and Folly, Scarlet. Scarlet Shade, and there's a bunch of them. What they do is they started out by taking a bunch of the barrels that didn't have homes anymore, and they mixed them, and they created great whiskeys. It says it speaks to
Much
the
like that
testament, speaks to the testament of blending whiskey. It speaks to the testament of this. I can't wait to try this when we get a little more whiskey in it. It speaks to the infinity barrel model. But I'll tell you, we were talking about 2024. Is there a whiskey in 2023 that you tasted that you were like, that stood out over all the others? And it doesn't have to be on our show. Just, I know you drank a little bit of whiskey last year. Is there one that, I know there's one, I think
I can't remember the names. I need to be rating.
Heimlichus Prime choked on some when we were here. I don't know if that one stood out.
The bottle that I really loved, and I think I went through 2 of them in 2023, is the Jefferson's Ocean.
Yeah. You gave me a bottle of that.
Yeah,
Are we
For
trading?
whatever reason, for me, it's just a great bottle. But there's a ton of good bottles. But that one, apparently I bought 3 and gave one to you. But
I give you another.
I've got
12
I've
for
got
it.
a half a bottle left, and I think I went through another one in 2023. So
I stumbled upon. Have you heard of an Amburana finish on a whiskey?
No.
It's a tree, I think, in Hungary that they make barrels out of, and there's only so many of these trees, and so they're rare barrels. Anyway, I think I got that right. If I didn't, we'll have someone. Please, if you're listening, correct me.
Please listen.
There's an Amburana finish Starlight that I felt like I was drinking a cigar. I swear to God, I felt like I was drinking a cigar. It's amazing, and I'll bring it to our next pour. But B-Love, I think this will be your jam. This will fit right in. I know this is strong.
This is good.
Well, and the proof says it's 100 proof, but it drinks hotter than 100 proof.
it's a little spicier than that.
It drinks a little hotter than 100 proof, but this
I love the flavor. Like
this Starlight, it's called a cigar batch. That's the name of it. It's a cigar batch, and it's finished in Amburana barrels, and these Amburana barrels bring a heavy tobacco flavor, leather.
we need to do a tasting then, because I've got the Old Elk cigar,
Good.
and I've got the Good Times cigar.
And then Barrel makes an Amburana finish as well.
Now it's not; those aren't Ambriana finishes, but
You'll be surprised.
they're
I think
cigar, whatever they. I didn't even actually look into why they're calling them cigar blend or cigar batch, but they're both good.
yeah.
Good Times is a great little distillery.
Yeah, I've got two. I got a buddy of mine, the guy that owns Happy Monk down in Norman. His name's Scott Tang. Wonderful human being.
Scott Tang.
Yeah, Scott Tang. He's a great guy.
Sounds like you're cussing.
He's wonderful. He has bought a barrel of Good Times and private barrel of his own, and he's called me and asked me if I wanted a couple bottles of it, and so I'm gonna $150 a bottle, but I'm gonna pick a couple of them up and see how they are.
Tim Forster's the one that told me to get a Good Times bottle. Shout out Tim,
Yes,
Timmy.
Tim Forster's got a collection.
or as he's known by those that know him, Earl. Won't say why, but I don't even know why. Actually, to be honest, but
I'm
but
gonna
he's
call him Earl.
He's Earl.
Yeah, Tim and I've exchanged comments back and forth on the Oklahoma bourbon drinkers.
Tim is a solid human being.
That's all I hear about him.
Good as they come. Well, thanks for sharing your Old Forester.
Yeah, cheers.
And your
This was all
time.
about-
B-Love. I'm
Opinions?
glad to be back. I'm
Yeah.
excited about the future, where we're headed. Looking forward to getting Dr. Bushman and some other guests on. Guys, it's been a great podcast. It's been a good year. How many 31 plus 8 is what, 39 days? All 40 days so far. I'm excited, guys. I think it's going to be a great 2024. I've got my passion back for getting in front of the client. I got my passion back for actually doing what we need to do. There's a lot of work out there for us in accomplishing our mission that we have set forth by creating this podcast. So
Agreed.
I'm excited about it.
And it's going to be a wild year because we're going to hear all kinds of promises from politicians in an election.
I
year.
know.
Yes.
We'll see how that goes. We'll hold them to it.
Alex, where can listeners find us?
All your favorite podcast destinations. Apple, Spotify. Well, we're not going to be on YouTube anymore for these, but
just up on
I'll give you a
YouTube.
bit of audio version, yeah. And what's the main one that we load to?
We use Spreaker. But
Spreaker.
I don't know if
you
that's
can
its
listen
own.
on Spreaker. And you can go to our website, healthcareucuf.com. It's on there.
We would love for everybody to subscribe. Your help in hearing what we do. And if there's something you think we can bless your organization with, we'd certainly love to hear
We
from you.
pay for this podcast through feeling good that anybody listened.
True.
It makes us feel so great.
It's a good fight. It's a really good, it's a good thing that's happening when just knowledge alone can drive the needle towards progression. So,
But it doesn't keep the lights on. We need some money. So listeners are important. I'm not gonna lie.
Sure.
We need listeners. We need people.
Oh, we
Share
do.
this with somebody. Tell somebody about it. We'd love to talk more to you.
I don't know about you. I run on warm fuzzies. I don't need money.
mm-hmm.
We're good.
That's all.